there. Welcome, everybody. Thank you for joining us tonight. My name's Allison Patillo, and I'm the publisher at the Aspen Times. And this is the Longevity Project event. It's a joint campaign between the Aspen Times and the Glenwood Post-Independent to help educate the community about what it takes to live a long, fulfilling life in our valley. It's not always an easy feat. This year, we're looking at traumatic brain injuries, or TBI, and long-term brain health. So let's start with an audience poll. Please raise your hand if you have had a TBI. And yes, a minor concussion counts no matter how minor. Okay. We're well beyond the state average. So in 2016, Craig Hospital did a study looking at this very thing across the state, and they found that 24% of adults in Colorado had some sort of lifetime TBI event. When you zero that lens in on Pitkin County, Eagle County, and Garfield County, the number goes up to 31% of adults. And yes, that's the high end for the state, as evidenced by the poll tonight. So those are pretty scary statistics, which is why we wanted to pull together this panel to help answer some questions, give advice, give us the latest information, and help everybody deal with TBIs the best way possible. So let's introduce the panel. We have Dr. Kathy Beauchamp, a neurosurgeon with the CU School of Medicine at Denver Health. We have Dr. Kerry Brega, a neurosurgeon with CU School of Medicine, Rocky Mountain Regional VA Medical Center. We have Krista Fox, an occupational therapist and certified brain injury specialist at Aspen Valley Hospital. We have Dr. John Hughes, the founder of TBI Therapy and Aspen Integrative Medicine, and another Valley local. And then for our moderator, we have Lee Tuchfarber, who is the founder and CEO of Renew Senior Communities. So it should be a really interesting talk tonight. We will have a Q&A after the panel, so get your questions ready. And then I want to thank our partners who helped make this event possible. First of all, Tuchfarber for this magnificent facility. We were all just saying this is the best place to do something like this, so we're honored. And then Renew Senior Communities could not have put this panel together without Lee's help. We've had lots of amazing conversations about this, and I'm excited to see where this goes tonight. And then Bank of Colorado. So, again, thank you all for being here. And Lee, I'm going to turn it over to you, but you need a microphone.
All right, well, thank you everybody for joining tonight. So I've had some preliminary conversations with this panel. Everybody comes from a very unique perspective on this one topic. So kind of hearing this blend as we interact up here is gonna be very, very interesting. So this will be a good sort of nerd session on the topic. So I'll start with you, Dr. Brega. Let's just start with sort of getting a foundational understanding of what concussion is, what TBI is. So if you could provide a definition for us.
Sure. There's a lot of definitions that are not helpful at all, but the one that I use is that it's a functional impairment of the brain that's caused by a trauma. Functional impairment of the brain that's caused by trauma. And any patient that we diagnose with a concussion has to have two things, always have to have the two. And one is signs and symptoms of a concussion, and the other is you have to have had a mechanism of injury.
So.
Mechanism.
So you've explained to me you've given me a metaphor before, like this analogy of what a concussion is. Why don't you elaborate? That was useful for me to hear.
Okay. First of all, it's important to know that there are about 100 billion nerves in the central nervous system, so there's a lot of them. And the analogy that I like to use for concussion is the old-time switchboards. So if everybody can kind of imagine an old-time switchboard where there's a lot of operators and they're all sitting there in front of the plugs. So imagine that there's 100 billion plugs, and somebody walks over to that switchboard and just goes bang, bang, bang. Well, some of those plugs are going to fall out. So service is temporarily disrupted. And as they get put back in, things return to normal, or they seem to be normal. But if you go back to that same switchboard and hit it again, you may not have the same plugs fall out. So I think it's kind of a good analogy, because concussions can be very different from one person to the next, and it can be very different for the same person having a concussion, from one time to the next. So it's not always the same symptoms, and it's because you have so many neurons, and the injury may be is not always going to be to the same ones.
Thank you for that. Dr. Beauchamp, what are some of the misconceptions that you encounter often about TBI?
Misconceptions. I think there's a lot we don't know. So what we get asked all the time is, how many concussions is too many? Is this a bad one? Versus, because there was a grading scale at some point. Now it has gone to, you're either concussed or you're not. So there is no grading of that. What kind of activity could I do? And you can get a concussion without actually hitting your head on things. You can get a concussion just by either blast injury, or, you're riding up and down, just a race car driver type thing. And so there's a lot we don't know yet about what technology we have and how to use it. I think things are a lot different than before when it comes to sports concussion, which is where most people take concussion. We miss almost all motor vehicle accident concussions because they have other injuries, they have severe injuries and maybe not have a concussion, but we don't really do any screening. And I think there was a paper that demonstrated that out of UCSF in San Francisco, 56% of minor car accidents probably have concussion, but they don't get screened because it's just not where we'd go yet. Now, for sports, we've made it so every coach in every state, now Mississippi included, last state, has to be trained, at least an hour on concussion. And so we treat it very differently, but we've got a really long way to go. So I think that just the general misconceptions are that that we know how many is too many, or how you should live afterwards, or what could be the next sort of thing to stop doing, especially with, again, sports and how they've done that, and helmets and the helmets they're making that are supposed to be helping, and mouthpieces and so forth, and that's not going to stop concussion. But
Go ahead.
Can I add something to it?
Of course.
I was just thinking about one of the things that I think of as a big misconception about concussion is that you don't have, it's not the same thing as having a loss of consciousness. If you have a loss of consciousness, you may very well have a concussion, but by far and away the concussions that we diagnose now, most don't have a loss of consciousness. I'd say 90% don't have a loss of consciousness. So in the past, though, that was thought of as synonymous, that a concussion is a loss of consciousness, but that's not true. You can have a loss of consciousness, but most of the time people with concussions did not.
Interesting. So that kind of gets to the point of, say, back in the day, historically, when there was far less known about head trauma. If someone wasn't knocked out, then they maybe didn't have the, quote, classic symptom of the time. And so they were all good, to go back on the field or, what have you, whatever they were doing. But now we know that concussions oftentimes exist without someone going unconscious. And then, so Dr. Hughes, we were talking a little bit before we came up here, and you were really going into an interesting area. You were talking about what's happening at the molecular level. We kind of understand what's physically, what happens observably, without a microscope, but what's really going on with the chemistry and, at the molecular level.
Thanks for coming to all this. What I've taken from is Robert Cantu is a famous neurologist who has a concussion foundation. He says that the brain's in a metabolic crisis in a concussion. And where I've taken that is to understand his words. It's like a bomb has gone off in the brain, or like a biochemistry lab. You think about all the chemistry experiments are in disarray. What he says is that the potassium goes extracellular. If you know anything about cellular chemistry, most of the time, C big K, if we remember from our biology classes, potassium stays inside the cell. So when it goes extracellular, that's not good. Calcium goes intracellular. And if we know much about biochemistry in that way, that usually causes apoptosis, so it kills the neurons or kills other cells. And then you end up with deficiencies in magnesium. You also have decrease in cerebral glucose utilization, as well as neurotransmitters are getting produced wildly. So at a very cellular level, a bomb has gone off in the brain. And what Cantu says is that it takes energy to put those cellular processes back into place and get the right kind of neurotransmitters back online in the correct way. Many times we see a hyper catecholamine release at a cellular level. We see oxidative stress, lots of glutamate, particularly as a neurotransmitter, which is a very neuroexcitatory transmitter. And then after this sort of hypermetabolic crisis that occurs initially, you'll see kind of a slowing. It's almost like due to this anaerobic respiration that kicks in. Hope this isn't going too much in the chemistry world, but you end up getting a slower metabolic activity, and ultimately I think that's primarily what contributes to a lot of the symptomology of traumatic brain injury. If you think of mental fatigue, physical fatigue, I see that in almost all my TBI patients. And when we correct some of those energy deficits, we start to see the brain memory, sleep, all that starts to come back online. And I can explain a little bit more, but there's lots of time to discuss. Yeah.
This is not fair, probably because I never asked with this before. With those theories, second impact syndrome, how does that tie in the sense of second impact syndrome is when you have a relatively mild hit or concussion. We don't say mild concussion, but something that's not that you don't get knocked out, no big deal. Then you get hit again, not very hard, and your brain immediately swells to the point of, it happened here in a boxing match that they had, and by the time the physician got into the ring, who was at the side, patient was dead. And so second impact syndrome is really what a lot of the schools worry about, and a lot of the teams worry about. So,
What was the actual cause of death?
immediate brain swelling.
Okay.
That would, even if we had stood there and done our decompression, person's dead within seconds.
There's no way to do surgery on it.
Right, and it happens about once a year somewhere with
So
football.
your question is, what is happening?
Is it, yes, do you believe, or maybe you don't have an opinion? Sorry, I sprung this one on you.
I'll just throw you this. I don't know how long does it have to be before second impact syndrome is a factor? Is that 2 days? Is that a week? Could that
Short.
be
Short.
hours? Okay.
Hours, yeah.
So
and it seems to be just like if you still have the symptoms from the first concussion, so it may be hours, it may be minutes, or it may be a week, and you just still have the headache, but you're playing.
So, I mean, what you're telling me is just that, if you get injured in any part of your body, somebody kicks you again, it's going to have, additive inflammation. I mean, that seems like.
Inflammation, yeah. Well.
I mean, the cells have been blown up. That's the bomb that's gone off. You're going to have all that extracellular fluid, all that edema, as a contributing factor. So the challenge, what I see is a lot of a lot of neurologists, a lot of doctors will tell their patients to go home and rest. The brain doesn't rest. It does, but not like other body parts. You sprain your ankle, you rest it on the couch for a couple of weeks, and it starts to heal. But you injure your brain, you sprain your brain, it's always working, right? Even while you're sleeping, your brain's consuming 20% of the oxygen and 25% of the glucose that you're intaking. So that's why it's really hard a lot of times for brain injury patients to actually sleep, because naturally when most of us sleep, we actually start to lower our respiratory rate. We actually take in less oxygen. So keeping the oxygen higher is actually what's actually preserving the brain's actually functionality and keeping that patient in some ways not well rested, but actually keeping their brain alive and functioning in some way. So that's part of the challenge is you get this kind of rat chasing his tail aspect with the brain injury. Sometimes the more the patient tries to function, the worse the brain injury gets. And even some of the therapies can be dangerous if they try to focus on the functioning of the brain. Anyway.
Krista, going back to a little bit of the definitions, can you kind of give us a good idea of what the list of symptoms are, what sort of the primary symptoms of concussion are?
Certainly. So it's good to always remember that the brain controls absolutely everything that's going on in your body. So there can be a huge variety of symptoms, and you've seen one brain injury, you've seen one brain injury. So it can manifest in a bunch of different ways, but some things that we tend to see are certain subcategories, especially for people that end up having problems for past 3 to 4 weeks. And oftentimes we can see cognitive changes, mood or emotional changes. Headache is a big one, changes in how the eyes move, and then changes in the vestibular, your inner ear balance system. So those are some of the primary areas that we see, and they're kind of classified as subcategories, again, especially in people that have symptoms for a long time. There can be a lot of overlap with those things, and the real challenge for us, especially after the initial injury has occurred, is to try and figure out what system is not working well in your body that is driving those symptoms. So oftentimes there can be changes in how your inner ear connects to your eyes. Your inner ear changes your balance systems. There can be changes in sleep as well. My apologies, that's another category that I forgot. But all of those can overlap. And so what we do in treatment is try and figure out what system is off and then figure out how to treat that system. And going back to the myths, it's for a long time it was you had a brain injury, just get back out on the field, you're fine. Then we went to your brain needs to rest. Now we have a lot of research that shows that you need to be doing physical activity within about 24 to 48 hours, and you will have a better recovery, especially people that are more active. So active physical exercise can help get you there. The challenge is that you have to figure out the just right amount. And so that's what we do in therapy is we try and figure out maybe you have a trigger of bright light. Maybe you have a trigger of being on a computer. Maybe you have a trigger of turning your head really quickly. So what we do in our rehab department at Aspen Valley Hospital, we've got a great team of PT, OT, and speech that work together along with the physicians, potentially the athletic trainers at the schools, to try and figure out what can you do. And we do a graduated return to life protocol that is kind of similar to what they've been doing in the sports world for what can you take. Let's not put your brain into a red zone where it's taking energy away from healing, and how can we get you progressing in your life to get back to where you need to be. So that's another myth that I think is important to include. And like Dr. Hughes said, the neurometabolic changes that happen in the brain, you can't see that on a scan. So you may go to the hospital and say, well, I had a brain injury, but there's no bleed, there's nothing on my CT, there's nothing on an MRI. We cannot see what is happening at that cellular level. There is a huge change in the metabolism in your brain for up to 3 weeks from what we're seeing in rat and mice models. So we know that the chemistry of your brain has changed. It's vulnerable. Another impact could be deadly. Another impact could prolong your symptoms or make it so that you don't have a complete recovery. So the real mystery is at that cellular level, what we can't see, what we can't draw blood out of your brain to see what's going on in there. But it's really interesting for what's going on at that metabolic level.
So that actually kind of brings up a question for me. having hung out with each of you a little bit before this, each one of you guys all are experts on traumatic brain injury, but you have different types of expertise. You guys kind of fit in this ecosystem of professionals. I think it'd be helpful for you guys to describe, where you sit within that ecosystem. Sort of what is your scope? What are you addressing on a day-to-day basis with patients? Because it's different, across the panel here. Dr. Brega, why don't you start?
Well, I think it's probably, both of us are probably similar, but what we deal with is the acute phase. So we're dealing with the car accidents and skull fractures and penetrating injuries and such, but we're also dealing with diagnosing concussions. I'm kind of tripping over that. Yeah, so I work for the NFL, and Kathy is the neurosurgeon for the Denver Broncos. And the NFL specifically asked us, because they are still investigating some issues, they asked us specifically not to talk about professional football or what we do on the field. So I'm kind of tripping over what do we do. So we do some stuff we're not talking about, but then otherwise, we do what typical trauma neurosurgery does, which is dealing with the acute phase of injuries.
That was a good one.
It's a great answer.
That was our disclosure. Right. So surgically, concussion is not a surgical disease. And again, as Chris said, you don't see, by definition, if you can see blood on a CAT scan, you don't have a concussion. You have a mild to moderate or complex mild brain injury. So a concussion has a negative CT scan, doesn't have to lose consciousness, and needs to have these symptoms. We deal more, I'm at the county hospital trauma center, so we deal more with the severe injuries, life, death, immediate surgery, that kind of thing, discussing, how long, when someone's been unconscious for 2 weeks, 3 weeks, how long do we go, that kind of thing. So in my hospital practice, we see really just the miserable minority, we call it, which is what you alluded to. Most people are better in 2 weeks, 2-3 weeks. There is this miserable minority that can not get better for years. And why those people have that and some people don't, not sure. Some of the worst concussions I've seen actually have not been...
More plugs fell out.
Oh. Good point. Yeah, we take pieces of bone off for brain swelling in the appropriate settings. We do a lot of intracranial monitoring for pressure. I mean, these are all patients who are completely unconscious and on the brink of life and death. So that's my job there. Now, at the job that we don't talk about, it's constant evaluation. We have obviously strict protocols that we're not talking about. And that's a different population altogether. Now, if you played football 30 years ago, which I'm guessing people do, you probably used to do drills where you hit each other intentionally in the head multiple times. And that you practiced all the time with hitting, where now they've really drawn back on those things, and they're trying to change the game from that. And so I think if you look back at the older teams, concussion was sort of funny. Like if somebody couldn't talk right or they couldn't remember the play, you just made fun of your friend and you went out and played. A little bit different now. So for sports, that's the part that's changed. What's most interesting to me, and has just a question if you're ever on Jeopardy, the brain rest, it used to be that they wanted total brain rest. I have 7 kids, so I'm very familiar with social media at this point. There's actually a syndrome that is named in Denver, maybe it hasn't made it up here, called, people get so anxious that they'll lose their Snapchat streaks, that they've allowed computer use for that reason. Because it used to be that, the computer really was hard and on your eyes and so forth. But the anxiety about the Snapchat streaks, which means that you Snapchatted the same person every day for, my daughter's up to 700 days on one person. I'm very proud of her.
That's very impressive. I'm impressed.
Yeah, so they have allowed those changes because of computer stuff, and we don't have any idea what that's doing to, it just can't be good. I mean, staring at a computer can't be good all the time, so that was just a random thing to know in case, like I said, you're ever on Jeopardy.
So before we move on to Dr. Hughes on sort of where he's focused, so you see patients, you see you're in the acute domain, and what are the types of accidents that bring people into your office, so to speak, which would be the OR? What are you seeing? Is it mostly sports? Is it mostly horse riding accidents, car accidents? What are you seeing?
Hideous. And more hideous as the pandemic went on. It's always been car accidents. We have at one point, about 10% penetrating trauma, so stabbing, shooting, that kind of thing. With the pandemic, we saw a 234% increase in child abuse, or we call it non-accidental trauma. We saw a 78% increase in gunshots. We did 6 in one weekend. And we do a lot of car accidents that are as a result of stealing cars, being on mind-altering substances. And very few just, I was climbing up a ladder, and I fell off type thing. So it's not even in the press anymore in Denver, but the violence there and what's happening down there is impressive.
That's I didn't know that. I find that really interesting, these secondary effects of another secondary type of effect from the pandemic that you guys see, but kind of invisible to the general public. Dr. Hughes, what's your area of focus? Where do you fit within sort of this pipeline or this track of healthcare for people with TBI?
Yeah, thank you. I see most patients, and just to give you an idea, they may have kind of just downplayed, because the surgeons do amazing things. If there weren't brain surgeons that were relieving the edema on these patients, many of them would die much, much quicker than they do. So, I mean, I've seen pictures of patients of mine that were in these ICU units, and they got feeding tubes, their stomach, their nose. I mean, everything the surgeons do to get them to a stable place, and then occupational therapists and physical therapists and vestibular therapists and vision therapists. That's kind of the first order of business for, I would say, first 2 to 3 to 6 to 12 months for many of the patients that even before they come see me. If they're not in a stable place, I'm not seeing any acute patients. I'm seeing subacute to chronically injured TBI patients. And why are they chronically injured? Because, like I said, the brain injury can be like a long-term condition. There's brain injury survivor groups out there because many people are living with the chronic, what we call post-concussive syndrome or symptoms of brain injury. So that's the patients that I see. They're like, hey, I'm better. I can walk. I can talk, because I couldn't do that right after I had the injury. My head's not swelling. Maybe I have a shunt put in. There's a lot of things that these guys have done to keep these very injured patients alive. And by the time they come and see me, they're functional, but they're not optimal. And so my goal is to get these patients, hey, I'm on disability, I'm unable to work, unable to have good relationships with my family because my moods are angry all the time, or I can't sleep very well. my memory isn't very good. I can't go back to work because I can't remember things, very quickly. I see those subacute patients, and I'm saying, hey, what else is out there from a metabolic treatment perspective on how to best treat you? And so I've taken the research. I mean, I'm locally a sports medicine doctor. I give a lot of injection treatments of platelet-rich plasma for people's sports injuries. And then I've taken some of the research from the sports injury world in that regenerative medicine. I've combined it with some of the research with Alzheimer's patients and come up with somewhat of an innovative TBI protocol. What we did we took the research from intranasal insulin that was being used with Alzheimer's patients back in the early 2000s, and we said, hey, what is insulin doing for the Alzheimer's brain? What is it doing to kind of bring the brain back on? And it's if we know anything about insulin, what it does for diabetic patients, it drives glucose across the cell membrane into this cell where the mitochondria are, where you can make ATP. So what they deduced from the studies and found out at a cellular level is intranasal insulin, as long as it's applied appropriately to the top part of the nose, will bypass the blood-brain barrier and get into the cerebrospinal fluid and help basically make more ATP. And what that looks like at a cellular level, it decreases CSF cortisol, lowers the inflammatory microglia. It increases hippocampal neuronal viability, increases neurogenesis at the hippocampus. This is all getting kind of technical, but what that does in a good way is give that patient more energy. And what they saw clinically with the Alzheimer's patients was that they had better word recall, better balance, and overall better moods and stability with their brain. So we took that research and applied it to traumatic brain injury and have found good support with the case studies that we've done. We continue to get more and more kind of resolved cases from these types of injury. We've combined also, if you think about insulin's kind of like the fuel injection. We've combined that with oxygen therapy, including hyperbaric oxygen, as well as some other growth factors we use from platelet-rich plasma to help patients in a way to heal them metabolically. I like to think about the brain like a computer. What I'm very focused on, in some ways like the surgeons, I'm very focused on the hardware. I'm fixing and giving raw materials to help plug that computer into the wall and get more juice. A lot of the therapies that come after what I do, or even before, including vestibular therapy or occupational or neurofeedback, or a lot of these other therapies are very much software reprogramming. You got to have both. You got to get into the raw materials for the brain to heal appropriately. You got to give it the right energy. Insulin's like fuel injection. Hyperbaric medicine's like a supercharger on your car. So if you know anything about that, we're blowing oxygen, helping give oxygen as the primary nutrient to the brain. Because we all know that the most important nutrient we all need right now is oxygen. You can stop eating for a couple days, for a couple weeks, stop drinking. If you don't breathe for a couple minutes, you're going to die pretty quick. So that is really kind of the essence of what I'm doing, is treating the brain metabolically to get patients back to work, back to driving, back to sleeping better, back to preserving their relationships and not getting anger outbursts or other things. That's just a piece of the puzzle. Afterwards, sometimes it takes software, reprogramming, psychiatrists. I'm just part of the cog in the wheel of treating brain injuries.
Really interesting. So, so the two of you're on the front end right after the accident, and if it's severe enough, they, come into your field. After they've been stabilized, and they kind of maybe enter your office, right? Now, Krista, what about you? Where do you fit into the puzzle, so to speak?
So at Aspen Valley Hospital, we have over 2,000 people that go through our emergency services a year with suspected concerned head injury. And then our emergency services has done a great job of trying to get those people in a bridge to our rehabilitation department to try and help people figure out how to manage their brain injury, how to get back to life. And so we work with people at the very acute level in that they may have come into the hospital with a tibial plateau fracture from skiing or something like that, and everybody was worried about their leg, but now they're in the hospital, we're rehabbing them, and our inpatient therapists and our nurses and our trauma physicians now are getting on their radar what happened to the head, and we're evaluating them day after day of for their brain injury to try and figure out where are their impairments. Are they safe to go home? Can they manage their medications? So the really immediate side of things. And then we will also get people that we're not able to manage certain things from a neurosurgery standpoint because we don't have a neurosurgeon, that they might be sent to St. Mary's or to Denver, University of Colorado, be treated there, and then come back to us for those moderate to severe brain injuries. So we work with all of them as well. So we're on scene pretty much right away. And then we get about 280 people that go through our rehab department with our certified brain injury specialist team, that we evaluate them all in the same kind of standard way to look at the primary systems that tend to be off from a brain injury and work with them on improving those systems, getting them back to life, and helping them learn how to live with their symptoms. What is the appropriate amount to do, when, how much? And then we always, since we have such an active population, we always test people at the highest level before we let them get back to any dynamic sports with the potential risk of any other injury. So the acute all the way up to, we even can get people years out. There's this misconception that you have a brain injury, you did your rehab for 3 months, you still have problems, well, tough. No. Beauty of neuroplasticity is that you can always continue to improve, and we can work with people on getting back to what they need to do. And oftentimes people can get some not great wiring. The brain rewires those connections on the switchboard. Maybe they just got a little bit wired incorrectly because it's never as efficient as it was before. So people can end up with maladaptive problems that can drive these problems for post-concussive syndrome and have things like functional neurological disorders, and we can work with them to get their brain back to being as efficient as possible. So emergence all the way through long-term, moderate to severe, whole gamut, we are able to work with that. And that's what a lot of good quality therapy teams that are experienced with brain injury do as well.
So the Roaring Fork Valley area is a very athletic community. Mountain biking, skiing, snowboarding, some stuff with elevated danger level, certainly, and more propensity to, get banged up, hit your head. So given that you're at Aspen Valley Hospital, what is the, just give us a sense of the volume, like what kind of numbers flow through your system with respect to head injury on an annual basis?
Well, as I mentioned, about 2,000 people go through our emergency department or one of the urgent care clinics in Snowmass, Basalt. They go through our primary care system as well, and then about 280 that we actually see for therapy. Some of those people I was mentioning earlier to our neurosurgeons is that we may only see somebody on the acute side of things, or they came to Aspen, they broke their leg, or they came to Aspen, they got a brain injury, they're only going to be here a week, and then we try and help get them to appropriate brain injury services in Texas or wherever it is. And really in the rehab world, we're still improving too. And it was only 3 years ago that we had really solid clinical practice guidelines for how the physical therapy world treats people with brain injuries. So not every rehab center is at a really high level and using cutting-edge evidence-based practice. But those are roughly the numbers, but I guarantee there's more. And there's a lot of people that had their bell rung and they think they're going to be fine, and they suffer, and sometimes we get them 4 months later, and they finally see their primary care physician and say, I've been having headaches and double vision for 4 months. Okay, so we could have helped them sooner. So there's still big gaps, whether it's from they actually go through emergency services and they never follow up with us, or they think they're going to be fine, and then their world falls apart, and that it can manifest as other problems. So underdiagnosed locally, especially because I think people power through it and they just get out there and go for it, but definitely worldwide.
What about adults versus children? What are you seeing come through your system?
A huge gamut as well, that we work closely with the AVSC and with the athletic trainers at the school, and we have pediatric specialists that can work with those kids, and all the way up into people in their 90s that were skiing and they want to get back to skiing. So we're there with them trying to help them get back to skiing. So huge variety. And on that note, Part of the Longevity Project blurb was about, especially for older adults, and there's a huge amount for prevention for older adults. There can be medication effects that can make you more at risk for falling, and falls are one of the biggest reasons why older adults get brain injuries, and unfortunately older adults are more likely to die from their brain injuries because of a lot of other things going on with physiology. But medications, staying strong, staying mentally active, getting your vision checked, those are things, and not doing risky things like getting up and putting your Christmas lights on when maybe your balance isn't that great. And staying active, staying well. There's balance classes locally, but there's a huge amount, especially for the senior population, as far as prevention goes. So just wanted to put that out there as well.
So you kind of hit on this. My impression is that 20 years ago, scientific knowledge in the area of concussion or traumatic brain injury was pretty minimal compared to today. But then, even today, I get the sense that we're in sort of the infancy of really understanding what is going on. So Dr. Brega, when diagnosing, how are they diagnosed? How are concussions diagnosed? It seems kind of nebulous.
Well, it's really those two things. Number one, you had a mechanism, like you're seeing the skier in the ER with the broken leg. So there was a mechanism. There was some kind of a fall. And you have to run through that list of symptoms. As you were saying, there are physical symptoms, there are cognitive symptoms, and there are emotional symptoms. So a lot of them can be very vague, but you have to ask. So, do you have a headache? Do you have any dizziness, any vertigo? Do you feel like you're have trouble with your concentration or attention or trouble? Do you just feel like you're slowed down? Some people have word-finding problems. There are emotional problems like depression, anxiety, or feeling agitated or irritated or easily frustrated, or mood swings, and like a teenager. So sleeping a lot, trouble sleeping, wake up a lot at night. So there are lots of different symptoms that are often vague. And so if you aren't alert to them, and if you don't ask them, you often don't find out. At the time that we're all in the ER and looking at the tibial plateau fracture, we don't know. And so we'll miss the fact that you also have a concussion. A lot of people will, a lot of these things that are symptoms of concussion may not be something that you're going to notice immediately. You might notice a headache. You might notice feeling dizzy when you're getting up and around, or feeling off balance, or feeling kind of like you're in a fog. A lot of those things, though, actually, you're going to notice, over the next day or so as you pick up a book and try to read and realize that you can't concentrate the way you normally do, or you don't have the same ability to focus on a task. Short-term memory is another thing that you're going to notice, not right now at the time of the injury, but over these next day or so, as you can't find the keys and where did I put that down? So those are things that kind of start to come up over the ensuing days. But it's important when you see a patient acutely with a new injury that you tell them what the symptoms are, so that they're aware of it and they know that if they go home and discover that their short-term memory is off, or they can't concentrate or have trouble sleeping, any number of these symptoms, if they know that that's what a concussion is, then you're much more likely to have that patient come back to your office in the next few days and say, you know what, I think I have a concussion because I can't do X, Y, Z. And that's really helpful, but it's all about education, and you got to make sure that they know what the symptoms are.
So
balance. Well, acutely, probably one of the best tests that we have is balance. It's been one of the things that's been the most telling for us, going through all of the neurologic exam acutely, balance has been one of the things that's been the most telling, that this person or player or patient does in fact have a concussion. So balance testing is really important. There's a lot of different ways to do it, but balance is something that, again, that patients need to know. You know, if you have a balance problem, that may be your concussion.
So it's based on symptoms, and it's sort of what's visible. I guess you can maybe take a cognitive test and try to get a sense, but it seems highly subjective. You know, there's and pretty vague. So what is like what's the future of diagnosis? You know, there are, for example, you can take a blood sample and determine whether or not someone has, you know, a disease, right? It's definitive. It's is there anything sort of in the future, in the distance, for concussions?
What you're talking about is what we call biomarkers, and that is kind of one of the concussion holy grails, is trying to find the test that we could do. Like, you want to know if you have COVID, you take a test, 15 minutes later you know the answer. And it's, you know, fairly definitive. It'd be wonderful if we could find it, and there are no end of studies right now on different things that we can hunt for in your blood to look for, to see if we can identify that, different kinds of scans that we could do. Is there something we could do that would show us it? But as of yet, there is nothing. But that would be an enormous advancement to be able to definitively diagnose it based on some kind of a test. I think we've made enormous strides diagnosing it as we are with the symptoms that we know and the mechanisms that we know, and teaching everybody that is a concussion and that needs to be treated as a serious issue. So I think we've made great strides with it. But there's nothing that would be better than if we could draw everybody's blood in the ER on the way in the door and say, oh, you've got a tibial plateau fracture, and oh, by the way, you've got a concussion. That'd be great.
So, yeah, go ahead.
So on that note, there are 2 recent FDA-approved biomarkers companies out there. They're looking at some different types of biomarkers, so that's still ambiguous. So like you said, it is in infancy. And then there are some other really interesting things on potential changes in how the eyes move and track that we're looking at. And some of the imaging is getting better, but that imaging is not available locally. It's very, very expensive for spectrometry and using PET imaging and everything to see functional changes in the brain. But it's an incredibly exciting area to be able to try and figure out, how can we dial in that metabolic piece? Can we see a metabolism change right when it occurs to know this person we expect is going to have problems with X, this person is going to have problems with Y, and then potentially we can dial in a lot more of these metabolic treatments earlier. It's exciting, but right now it's pretty novel. So I think that someday those will work hand in hand very, very well. But right now it's very young. There's differences in what they're testing exactly, how they're preparing treatments and all sorts of things. So incredibly exciting, but to be continued on that one.
Is there anything that parents or spouses, you know, if a parent sees their child on the soccer field, you know, had the ball and afterward he's not feeling very good, is there a test? Like, are there apps yet for the iPhone or the Android? Like to measure what exists today. Does anybody have any sense of that?
I'm happy to jump in on that one since I work with the athletic trainers. So there's a lot of tests out there. Some of them are not really standing up well in the research. You may have heard of impact testing, and that is a baseline test that you do at the beginning of the season. It checks cognition, reaction time, those sorts of things. Unfortunately, teenagers, being the manipulative little beings they are, oftentimes will try and tank those tests so that when they get tested later, when there's a suspected brain injury, that they look even better than they did before. So it's not standing up in the research. The reaction time of that one is actually standing up decently well. There's some other apps and things that are looking at eye movements, but again, it's a baseline test compared to later, that if you purposely tank it, because they know what it's for, then it doesn't stand up. But they are looking at some normative data with goggles that track eye movements that potentially could. Right now, the standard of care from the International Consensus of Sport is a test called the SCAT-5, which is a sideline concussion assessment tool, and it's in the 5th version. They just met recently in Amsterdam last week, so maybe we'll get something new from the International Consensus of Sport, but that's something that can be done, and it's really easy to train athletic trainers, coaches. It's a pretty easy grab the paper test that you can. Is it 100% definitive? No, because again, right now, concussion is a clinical diagnosis, and it's really helpful to have somebody that's familiar with it.
Very interesting. And so, Dr. Hughes, so that's on the diagnosis front. What's the future, say 10 years out? You know, let's give it some time and for some technology to develop. What's going to be on the horizon for treatment? You know, for eliminating symptoms.
Yeah, and I'll just give you just a little plug on the diagnosis too. My firm is currently working with a group that works closely with Stedman called A&P Recover, and I think that's the future of medicine. It's a digital platform that actually we're developed basically like a patient tracking app that says, hey, how are you doing today? And it's literally an app on the patient's phone that says, oh, I'm happy, or I'm feeling bad, or it's that quick of a feedback 1-minute survey. Because what we're trying to do ultimately is keep, especially in the military world, keep these patients from falling through the cracks, because suicide is a very real side effect of any TBI. I mean, patients self-medicate with drugs, multiple pharmaceuticals, and the vets have no limits on any of that. So, and then many of the patients I've worked with had a gun to their head because of their TBI. So it's very important, this sort of diagnosis as well as prognostic tracking. And I think that is ultimately the future. There's a company that's doing this pretty good. They're called NeuroFlow out there, and they've been used in the field, and they have a very good app. We're modeling what we're doing from a treatment platform as well as a kind of a patient tracking. And what we've done is come up with like something. This is some of our innovation, but it's called an AMP TBI score, that we're looking to take symptoms. Some of the innovative tests that are out there, we're using voltage scans that are based on quantitative EEG. Some of the other basic symptoms, standard assessments of concussions. And we're kind of trying to combine all that into one quantitative score. So I think that is the future, whether it's done by my group or somebody else, is like, hey, how do we, and no TBI is the same, but how do we really assess where this patient is going, not initially only, but prognostically down the road?
So that's data collection, right? Yep. These really cool advanced methods of data collection. Do you see anything on the horizon that are actual therapeutics, whether they're medications, pharmaceuticals?
Yeah, I mean, we all know, if you're in the medical world, we know what these patients have taken. And just to back up a little bit, many TBI patients are confused as mental health only patients, rather than having a neuropsychological or neurologic insult as their primary diagnosis. They get thrown into the psych world, very much in the VA world, or there's so many mental health patients that may have depression because at a cellular level maybe they're suffocating, or they don't have enough energy for their brain to get through the day, and they're depressed because of that. I mean, there's mental health patients that are getting prescribed many drugs, commonly SSRIs, SNRIs, and that's very dangerous for these types of patients. It's really actually contraindicated. They're not FDA approved for this type of thing. And then there's the stimulant drugs, Adderall, modafinil, and then there's the slow down drugs, trazodone, Valium. So they're pushing the gas with some of the stimulants. They're slamming on the brakes when they try to go to sleep. It's just polypharmacy of drugs, which I think is not the right answer. If I had to say one drug that's generic, and probably still what I'm promoting as the future is insulin, and diluted appropriately, administered appropriately. It's something that can be bought even over the counter now in many states and diluted in, I've taught many patients how to use that and help their brain. I think that is the future in many ways. Oxygen is the other drug that I've been using, of course, as hyperbaric oxygen. What we know, and the reason we use hyperbaric oxygen is because we're trying to improve the brain's partial pressure of oxygen. When you breathe oxygen in a concentrator or an oxygen tank or something, you're getting oxygen upregulated in your system for about an hour maybe afterwards. With hyperbaric oxygen, you get 24 to 48 hours of higher concentrations of oxygen. What that oxygen does at a cellular level is it lowers inflammation, increases glucose utilization, all the things that kind of correct things metabolically. And then I think the future of kind of what I've been doing is taking blood, concentrating out the 300 different growth factors in platelet-rich plasma, and then administering that directly to the brain as well. That's what I've seen as the future and has worked well for me over the past 10 years. There's plenty of other neuropeptides, peptide therapy, there's plenty of other therapies that are out there. I think, virtual reality and some of the neurofeedback, TMS has some merits if it's used appropriately. I do think that going after this metabolic crisis is really the key. Drugs that are supportive but not kind of where they make the patient dependent on it is good. But I think we have to ultimately start reducing this polypharmacy of drugs that are being given to way too many doses and way too much to many of these patients because it puts them in this very disoriented and very hard to heal state.
So you, really briefly, you mentioned that insulin and oxygen are key. And do they synergize? Do they work better together versus?
Yeah, if I use insulin sometimes without using oxygen therapies, it's kind of like putting too much gas and flooding the tank on your lawnmower or something. So the engine, it can be challenging for the patient. So you can't have too much. You got to have that right fuel oxygen mix.
And then the insulin, the delivery method is really interesting, where you go intranasally, so it actually gets right into the brain through the blood-brain barrier, right?
We teach patients how to do that with a tuberculin syringe. So it's very easy. Some of the early studies were actually done as a blaster, kind of blister pack that would stay up here and shoot the insulin up. We found that if you have the patient lay back on their edge of their bed, keep their head supine at 85, 90 degrees, they can administer the insulin themselves. So
Very interesting. Okay, so we'll transition here. We'll do about 15 minutes of audience Q&A. So there's Ben. Ben's got a mic. So anyone, go ahead and raise your hands, and I'll, I guess, try to point. Sir, go ahead. You're right near the aisle.
So a lot of the discussion you've been talking about has been on the metabolic standpoint. So a lot of the work that I do in my office is working with brain health, because not only have there been concussions that people have been dealing with, but the accumulation of stressors, not only physical or structural, mental and emotional, toxic and nutritional. And you mentioned one of the main functions that people are having issues is sleep, focus, mood. And a lot of the work that has, as far as the brain function, deals with brain waves. And so, like if people are having trouble sleeping, they can't get into deep delta waves. Or focusing, their alpha waves aren't there. So in a sense of accumulated stress disorder or stress brain syndrome, like Krista mentioned, the brain controls everything in the body. And so there are different aspects as far as improving brain function, whether it be light and sound therapy or working with the prefrontal cortex and cognitive functions that are concerned, that can help create these neuroplastic changes. Where would you see this type of work, or where would you be open or interested in incorporating that kind of work with what you're doing? Or anybody else?
Go ahead, Krista. You start. I can tell you were ready to.
There's a huge amount of interest in brain injury right now, and I feel like it's such an emerging place, and it's in its infancy, and there are a lot of things that we can and should try. But we also need to try and stick to an evidence base to it. And so if it is working for people, there's no downside. certainly, I think that there are lots of options and different ways that this can go because people respond to different things in different ways. So some people may respond really well to some of those things, some people may not. It's still on a, we will need to see, but I think that definitely it's worth trying just about everything because living with a brain injury is incredibly debilitating, it's incredibly expensive, it's hard on the whole family. So I think it's pretty much wide open for trying things within an ethical framework.
I'd like to add, we used to do brainwave therapy a lot with our patients. We actually had a special guy in California that designed specific brainwaves for each of our patients. And putting patients into a more theta state, if we know anything about brainwaves, a calmer brainwave states. In general, what we see from a brainwave is patients live in either theta or they live in alpha. So alpha is the very fast brainwave. We think about driving the car fast or getting chased by a bear. And then alpha is that learning state, that kind of calm, reading a book, relaxing, meditating a little bit. Theta is that daydreaming state. And a lot of patients either go between theta or they go, or they're in high alpha, high beta. So they're in this, beta state and they're running from the bear, or they're just daydreaming. And because they don't have the energy to kind of constantly stay in the appropriate, conscious awareness of alpha. And so I think all of those things can be very helpful as long as they're done appropriately. We would give some of our patients these soundtracks, and then they would be like, well, I'm feeling like the world doesn't mean anything. Or they would have these kind of like disassociative states that it might be pushed. So I think the appropriate type of practitioner, I'm a big fan of what you offer, the brain tap. I love that stuff as long as the patients can tolerate it and they don't overdo it. There's definitely a level, even with these digital drugs and brainwave drugs, that you didn't overdo. And that's where I think a skilled neurofeedback versus just entrainment can be very helpful. So.
Thank you.
Thank you. Sir, back at the wall.
Good evening. I have three quick questions. When I reviewed the literature a few years ago, it was 12 months post-acute injury that you would see the most dramatic improvement. Then it became 24 months more recently. How long are you seeing improvement in brain injury? Dramatic improvement, not nominal. After how long?
Our words now are, once you haven't seen improvement in 6 months, you're at your plateau. So
6 months.
6 months of being the same. But if you're 4 years out and still improving, you're still improving. But once you stop for 6 months, you're probably where you are.
Okay. And then Dr. Hughes, again, when I looked at the literature, the hyperbaric treatments were never frowned upon. They don't hurt you, as long as you don't blow yourself up by smoking a cigarette or something in the hyperbaric chamber. But the Israelis were using them regularly for brain injury, TBI, but no one else was, really. They weren't really prescribed or used. Are you seeing really legitimate improvement using hyperbaric by itself? And are there any peer-reviewed studies that are supportive of that, other than your own experience?
Absolutely. The guy who's done the most research is Paul Harsh, and he's a board-certified, I believe, ER physician down in Louisiana, and I think UCLA, I think. But I'm sorry, University of Louisiana in New Orleans. But he's done the most research. Look on his website for plenty of studies. You can look on my website too, but hbot.com, I think is his, Paul Harsh's website. He's done multiple studies. Now, the problem with what you said is by itself. As a monotherapy, what the military did studies, and they saw that there were, improvements, but a lot of times the patients after 6 months would hit this cognitive plateauing and even some decline. So I definitely think what we know with hyperbarics from a cellular level is after 25 treatments at 1.5 to 1.75 atmospheres, you get an increase in angiogenesis. And increasing blood flow, increasing oxygenation definitely has a beneficial effect on the brain. At this stage, I think it's cost prohibitive to do for every traumatic brain injury in the way that Dr. Paul Harsh has done it as a monotherapy. I think there's there's room for a lot of innovation, and not even just using hyperbaric oxygen, but even lower pressures, just to give patients a little more improvement. The verdict is out. It's actually been approved in some states for PTSD and TBI for military veterans. I think the money hasn't been allocated, but even states like Oklahoma and I think maybe Texas have approved it. So it's becoming, plentiful, and there's a lot of research. I don't know if mainstream insurance and car insurances have covered those treatments for my patients. I don't know if mainstream insurances will ever go there yet because of the cost prohibitive nature of it.
Thank you. And my last question is, you mentioned a vision monitoring with goggles that can maybe help either diagnose or identify a brain injury. I'm familiar with nystagmus, but can you expand just a little bit on what that vision monitoring does to tell a physician or healthcare professional that there's been a brain injury? Thank you.
So that came from a neuroscientist that's in California, and they put goggles on your eyes, and then they have, I believe their letters appear on the screen that you can see, and what they're looking at is how quickly can your eyes move from one to another. It's called a saccade, and saccades are an integration of a bunch of different areas of your brain, and the idea is that if there's a slowing of that there is likely some brain impairment. So that's one example of a novel thing that is out there, and I believe did get FDA approval 2 years ago for using that, but it is not widely used. But that's what they're looking at, is the quality of movements that are quick from one point to another. Mm-hmm.
I don't know if I'll go all the way over there to the microphone, but I didn't know really what I was going to ask, because I've learned with brain injuries that you don't ask questions because often you don't get answers because they're all so different, right? Can people hear me? Yeah. Okay. But my heart kind of stopped when you said 6 months, because my husband is almost at 6 months. He is at Craig right now. His injury, he's been through at least 3 of your phases, not to Dr. Hayes' phase yet, and certainly I've looked at many things, alternative therapies, if we want to put it under that category. But when you're undergoing acute phase and all of those stages, there's not a lot you can do. He's been, had all of those, not all of the drugs, but many of those drugs you mentioned. And fortunately, he's doing really well, but we are almost at 6 months, and we see a continued progress. He's doing great. He's been at Craig for about 4 months, 4.5 months, and we are now going to QLI, Omaha, in Nebraska. I guess I just, my heart kind of stopped when you said that, and I believe he's getting better, and the team believes he's getting better. He's very cognitively aware now, and he has aphasia. But yeah, it's a journey, and it's
What kind of accident was it, if you don't mind me asking?
a ski accident. He had a diffuse axonal injury, so not a closed cranium injury. He did have a tibia plateau fracture, unfortunately, and I don't think it was avoidable. They did see that he had a brain injury. Hughes went to Aspen, flown to St. Mary's, and then 3 weeks later went to Denver to Kindred for a long-term acute care for 3 weeks, and then we were fortunate enough that he got into Craig right away. Physically, no other injuries, so again, we were really fortunate that way outside of the tib-fib break and closed head injury. And then when they did do the secondary MRI, once we got to Craig, they did feel that it was just displaying a lot better than they originally had thought. The one thing that they contributed to his long, this long span of recovery was the possibility that maybe there were some previous head injuries. Big biker and had been taking some falls in the last couple of years, and
No, it sounds like he's improving a lot, and most people then go to QLI, and the improvement there is unbelievable. I follow personally quite a few patients, for a decade or more afterwards because we become friends. You're with them all the time. So, I mean, you're still in the improvement phase, and there's going to be a lot more. So, I think you're good in that way. I guess the one thing I'll say about why somebody takes longer, diffuse axonal injury is different in everybody, but most importantly, age has a factor, and if we could all be under 18, it'd be much easier.
We have a lot more head injuries.
Yeah.
Well, if you survive your head injury as a child, you almost wake up 100% of the time. Not true, and being old now is like 40, so it's kind of, yeah, yes, yes, and I'm much older than 40, so it's kind of.
Go ahead over there.
I actually work in EMS in Valley for Aspen Valley Hospital, and we do have a pretty robust TBI protocol in place. But I was just curious because we deal with a lot of it. Often these patients are treated by other substances, marijuana, alcohol, fentanyl, getting some of that up here now. Is there anything coming down the pike to improve our care to give you a more salvageable patient, including stopping that catecholamine cascade and the apoptosis? When does that start in the injury process? And also, what is having an additional substance on board? How does that affect, I'm guessing, deleterious in the recovery of the TBI?
Could you summarize the question or use the microphone, please?
Yeah, does someone want to?
Yeah, so the question is, if somebody is injured, this is an EMS perspective, and they have other drugs on board, such as fentanyl or marijuana or any combination of such, is there something they should do to help with that? And what more could they do for the catecholamine rush and so forth after a brain injury? Is that a good summary?
Pretty much. Because we do have fairly robust TBI protocols as well as really strong pass-down
Yeah.
criteria. So we usually have a high antecedent suspicion of anything involved in alcohol, substance abuse, falls.
Right. It doesn't help things, but as far as pre-hospital, airway. So we do know that airway and blood pressure are the most important, from the old trauma databank studies. If your blood pressure is low and you have a head injury, your mortality goes up by, hundreds. So also, I used to be a paramedic before school, before medical school, and when we transported down the mountain, we'd load the pram backwards, so at least their head was up, because position does make a difference. Small things. As far as the fentanyl, marijuana, and so forth, there's a lot of grants right now on how marijuana is affecting things, but the jury's still out.
Yeah, I just want to say a few things just about the catecholamine. What we know, and this is research out of University of Utah, I believe, Perry Renshaw, people that living at high altitude have much more catecholamines in their system versus people that live at sea level. That's one of the reasons I think we have a much higher suicide at this level, because we have high catecholamines, we actually have lower serotonin at living at higher altitude. And there was some research that was done that they hooked up patients for 15 minutes to 15% oxygen and then 60% oxygen with concentrators. And within 15 minutes, the guys that had oxygen had 4 times the serotonin blood levels that the patients that were at 15% oxygen. So just giving the patients oxygen, and the other thing that's kind of become popular, and they even make some of them, is like a head cradle made of or ice packs. They actually make special devices that are designed to put ice on there. And you guys correct me if you're wrong, but for anybody I've seen with swelling of the head, I think keeping their head elevated and putting some ice on it is first order, and giving them oxygen, which is probably what you're already doing anyway. So.
We've had a number of experiences where people, where someone arrives at, is delivered to the ER, where it appeared that they were under the influence of any number of other drugs, and it's our practice, and probably it's the practice here as well, to always do a drug screen. Because every now and then what you find is what you thought they were on, they're not. We've certainly had people where we were confident that they were, drunk, and they weren't, which is, of course, very, very telling and eye-opening about the extent of the injury to the brain. So anyway, it's always just good to make sure that that's checked.
All right, we've got time for one more question. Go ahead.
I'm also really short, so. Hello. I have a 12-year-old son who is recovering right now from his third concussion. And my question is, it's difficult, especially living here, where everyone's so active and he's a 12-year-old boy. A lot of his sports programs have a rule where, sorry, I'm really short, where 3 concussions and you're out of the sports program. And I was wondering, is that just a number that they've picked to be safe? Does that number mean something? Because it's really hard trying to navigate as a parent, like your son's mental health versus his physical health. So, thank you.
We all have an opinion. I'm not sure we have an answer. Yes, having kids of my own, I have 5 boys and 2 girls. The 5 boys all play football. So that's a question I get often is, would you ever let your kid play? The most concussion actually comes from cycling, if you want to be a purist about it. Girls soccer, lacrosse, all worse. Hockey just has it hidden along with college football. The number 3 I have not heard of, nor I'm trying to think if I would. You really just can't put your kid in a bubble, because they could just as easily fall down the stairs, or in our case, when they're pounding the crap out of each other for no reason. So that's my opinion. I don't know if there's any research on it. That's just a completely opinion-based, so somebody can say something smarter than that.
Well, this isn't going to be any smarter, but I think that all this, I've heard that multiple times, and it was just, I heard it when my son was in high school too, that 3 concussions and you're out, and I think there is evidence that we always worry about the effects of multiple injuries, and is there a cumulative effect, and there's a lot that we don't know, and so everybody's nervous about it. And my opinion is that the schools pick that to protect themselves, because we're all nervous about something that we don't truly have a lot of information about. And so, my son plays football too.
Well, there's more questions, I know. I think, for fairness of timing, some people might need to leave. But we'll conclude now, and there might be, maybe you can get an answer after we head off stage. But I just want to say thank you to the panel. Thank you for coming out here and providing your expertise, this array of expertise. And I want to thank the audience for attending and giving the panel an opportunity to share their knowledge. And I can imagine that this will catalyze additional conversations, ideas, maybe some therapies that people hadn't known about that they can now pursue. So that's a good thing. So with that, thank you, Allison Patillo from the Aspen Times, for putting this event on. and everybody enjoy their evening. Thank you.